I have a special interest in women's and pelvic health. Definitely, it's something that unfortunately affects a lot of women in general, but also with those with neurological conditions as well. So I'm really passionate about sharing whenever I get the chance about pelvic floor health, and definitely I think there's a lot more that you can do about it that people don't realize. So that's kind of one of the things I love doing. So in terms of today, with the pelvic floor, I want to first talk about what the pelvic floor is itself, and then what is pelvic floor function and what is healthy function. I'm then going to talk about some common pelvic floor problems, and then particularly how Parkinson's can affect those common issues, or why Parkinson's people are predisposed to those issues. After that, I want to talk about pelvic floor management and what physiotherapy can do in particular, because there's definitely a lot of things that can be done. And depending on how we're going on time, I'd love to touch on pelvic floor training and what that actually looks like in real life. So first, let's talk about what is the pelvic floor. To talk about the pelvic floor, we actually have to consider the pelvis first. So the pelvis is a bony structure made up of 3 different bones. So we have our wing-shaped bones that sit on the sides. And in the middle, we have our sacrum. So it's a wedge-shaped bone. That's the bottom of our spine. All 3 bones link together to help form what's called our pelvic ring. And then within our pelvic ring is what we call our pelvic cavity. So within that hole is our pelvic cavity. And then within our pelvic cavity sits 3 major organs, and that just depends on our gender, which I'll touch on a little bit later. So I also just want to talk about the differences between male and female pelvis. So with the male pelvis and the female pelvis, actually the bones are all the same. It's just that the shape of them is a bit different. So with the male, the pelvis is typically a little bit taller and narrower. It actually has more space for muscle attachments, and hence it's a little bit better at producing power and strength. Whereas the female pelvis is a little bit shorter and wider, and it's more built to be adaptable. So it has that capacity to open up wider as we give birth and things like that. So those are the main differences there. When we talk about the pelvic organs, of course, there's some really big differences there. But when we look within the pelvic cavity, let's say looking at females first, we have the bladder at the front, we have the womb and the uterus in the middle, and then we have the rectum at the back here. So this is our bottom at the back here, and this is the front of our body at the on that left-hand side. When we look at the men, so we still have the bladder at the front, and we still have the rectum at the back. And then underneath the bladder, we actually have the prostate. So no uterus or womb, but we have the prostate in the men instead. So even though there's differences between the bony structures of both men and women and the pelvic organs between men and women, the pelvic floor muscles themselves are actually very similar. This is something that I want to talk about a little bit later on, but let's get back to the main question, which is what is the pelvic floor? So the pelvic floor is actually the floor of that pelvic cavity, and it helps to support the pelvic organs up within that space to keep them up nice and high where we want them. And it's made up of both muscle and also fascia, or connective tissue is the other word for it. So things like ligaments, which help attach sometimes bone to bone or muscle to bone things, that's what we call our connective tissue or our fascia. And so if we have a look at this hammock analogy here, it's almost like, so our pelvic floor almost sits like a sling underneath the organs, and different parts of that sling support different parts or different organs at the time. And for example, fascia will be like the rope that helps connect that sling up onto the bones, which are these stumps here. So looking a little bit more specifically at the anatomy and what those muscles actually look like. So first, to orientate ourselves, we have our pubic bone at the front of the body. We have our sacrum, or the bottom of the spine, at the back. And so we have the back of our body here, and on that left-hand side, the front of our body. We have our pelvic organs. So we have our bladder at the front, our uterus and the womb in the middle, and then our rectum at the back. We also have depicted here our core muscles. This actually wraps around the whole trunk here, almost like a corset, and helps to support the whole trunk when it activates. So looking specifically at the pelvic floor muscles, we have two layers actually. So we have our deep layer, which is that sling layer that helps sits underneath the pelvic organs. So just over here. And it helps to, when it contracts, it helps to lift up on the pelvic, lift up under the pelvic organs. We also have superficial muscles, so the ones that sit more around the exits of the body. So the one that sits, so we have the external anal sphincter, which is where that that little muscle is right now. We also have muscles around the urethra and the vagina as well, and they help to, when they contract, they help to squeeze around the exits. So this is important when we think about pelvic floor training later on, because when we contract our pelvic floor, it should feel like a squeeze and a lift together. And then just having a quick look at the fascia, or that connective tissue we talked about, it's definitely more complicated and interwoven than the muscles. But just to give some examples, we have certain ligaments that help to attach the uterus up against the bone. We also have different fascia that helps to separate between the organs as well. So depending on where we have injuries with these things, sometimes it can cause different effects. But that's not too important for today. So then when we have pelvic floor muscle and pelvic floor fascia or connective tissue working well together, we get good pelvic floor function. However, if there's an issue with the pelvic floor muscle or the pelvic floor fascia, then pelvic floor problems can arise. So I just wanted to give a bit of an analogy of how that works together. So when I think about these things, I like to imagine a bowling ball on a trampoline. The bowling ball represents our pelvic organs and the weight of them, whereas our trampoline represents that fascia that sits underneath and supports. Let's say firstly, if I was just to leave the bowling ball on that trampoline by itself, what would happen is that probably over a long period of time, we might see a little bit of dropping or a little bit of sagging in that fascia, just because of the weight over time. But let's say if we go to bounce the pelvic floor, bounce the bowling ball on the trampoline, what happened? We'd probably find that the fascia or that trampoline will wear down a bit faster, and it might drop down a little bit further over time. And so that's equivalent to what happens when we run or we jump or we even stand up. There's increased pressure down onto the pelvic floor, and so increased pressure down onto that trampoline. But let's say if I was to go underneath and then push up every time that the ball bounces down onto the trampoline. So if I was to push up just at those critical moments when there's increased pressure down, I help to kind of take the load off that fascia or that trampoline. And so then over a long period of time, we might find that there's even less stretching, that it stays up high where we want it to be for longer. And so that's really what the muscles and the fascia do. So the fascia is always supporting those pelvic organs, whereas the muscles help to turn on and turn off just when we need them to help take the load off. Okay, so then coming back to that, that's why the main, if we look at the simplest form, when pelvic floor problems happen, it can be one of three options. Option one being it can be a pelvic floor muscle problem. Option two being it could be a pelvic floor fascia or connective tissue problem. Or option three being it's both together. Okay, so now looking at kind of common pelvic floor problems that can happen. There's three main categories when we talk about them. There's other things that can happen, of course, as well, but these would be the most common. So our first category is our urinary disorders, so our bladder problems. Our second category that particularly affects women more than men is our prolapse disorders. So that's when any combination of the pelvic organs can start to drop down a little bit lower than where we want them. We're not going to talk about that too much today. That's something that's a little bit more related to childbirth instead. And the last category are our bowel disorders. So issues with incontinence or fecal incontinence or constipation, which is something that we'll talk about because it's actually quite common in Parkinson's disease. And so it is estimated that 2/3 of all Parkinson's patients have some degree of bladder problems, and that's just from an article by the American Parkinson's Disease Association. But what we might see in a sec is that potentially that number might not be accurate. Okay, so well, this slide just shows the results of a survey that we actually did with our Parkinson's patients at our clinic. And so we just did a little simple survey to see what kind of symptoms they were getting. So we can see out of 21 participants that actually 8 of them, so 38%, seem to have some degree of stress incontinence, which is leakage when there's a cough or a sneeze. And about 18% or 86% had urge incontinence or frequency. So that's when you either need to go to the toilet really often all the time, or maybe you get a really strong sudden urge all of a sudden without really having needs to go maybe a few minutes ago. 9 out of 21, so 43% had issues emptying. So whether that be emptying the bladder or the bowel, so that can be constipation. And it can also feel like you're not emptying your bladder completely. 4 people out of the group had bowel incontinence, and 1 person reported sexual dysfunction. And so the interesting thing to note with this is that actually 41 of these participants were actually male. So I think that goes against that conception that pelvic floor issues are just a women's thing. It definitely affects men, unfortunately, as well. And so today I want to talk about those most common ones. So we'll talk about stress incontinence, urge incontinence, and difficulty emptying. So talking about stress incontinence first. Stress incontinence is when there's a leakage of urine during a cough, sneeze, jumping, running, even just sometimes standing up from a chair. And it refers to leakage that happens with a mechanical pressure downwards onto the pelvic floor and onto the body. So the common causes with this issue are often a weak or a lax pelvic floor. Sometimes if the pelvic floor is injured as well, that can be something that contributes. The other things that can cause this issue can be poor coordination of the pelvic floor. So the pelvic floor is designed to automatically contract when there's pressure down, but sometimes maybe if people have gone through a lot of infections or a lot of pain, that kind of normal process can be disrupted. And so we have to do training to bring back that coordination. The other thing that can cause this issue is age-related muscle loss. So as we get older, there's definitely a tendency for us to lose muscle mass throughout the body, but this is definitely something that's reversible with exercise and with stimulus. So in terms of the literature or the research, there's no clear mechanism that's been identified to say why this is necessarily more common in Parkinson's disease. However, because we know that one of the main symptoms of Parkinson's is like reduced muscle strength, sometimes reduced amplitude and speed of movement, it does make sense that maybe this is more common because maybe we're not contracting strong enough, or maybe we're not contracting fast enough or hard enough to really support the pelvic organs when we cough or sneeze. And so when I think about like how does a weak pelvic floor cause leakage, my favorite analogy to use is actually thinking about a leaking hose. So let's say if I wanted to stop the hose from leaking and I had a solid wood floor underneath, if I was to step down onto the hose, what would happen is I'd probably be able to stop that leakage quite easily because there's a firm back pressure from the wooden floor there. And that's really equivalent to us having a strong or a taut pelvic floor. Having a weak pelvic floor is almost like trying to stop a hose on a trampoline. Because the trampoline has a lot of give and it's not nice and firm like we'd want it to be, when I step on the hose, even if I'm using the same pressure as before, you might find that there's still a little bit of leakage of urine. And so essentially when you cough or sneeze and you have a weaker pelvic floor, that's something that can happen. So the other common issue that we have is urge urinary incontinence. So that's when there's a leakage of urine associated with a strong sudden urge to urinate. And so this is the type of incontinence that sometimes people experience with triggers. So maybe they feel a really strong sudden urge when they start to turn the key in the door, or when they start to hear running water. A few of the women I've talked to, it's when they see their garage as they drive up to their house that they start to have a really strong sudden urge. And essentially what happens with this issue is that we get inappropriate spasms of the bladder wall. So the bladder wall is squeezing and contracting at the wrong times. Often the actual cause of this one is a little bit more complex and multifactorial. It's often not really a case of weakness as such. This is definitely an issue where it's quite important to see a health practitioner as we can. And it's often a condition that's associated with urinary frequency. So you're needing to go to the toilet more often, or like maybe 10 times or more in the day, which can be quite disruptive. And so this issue is more common in Parkinson's disease, as people with Parkinson's tend to have overactive pelvic floors. This means that there's a greater tendency for the bladder to squeeze down more frequently, regardless of what volume might be in the bladder, so regardless of how full our bladder is. So as we can see, to illustrate that a little bit more, if we look at that table on the right, a normal bladder stays relaxed as it fills up. So let's say at maybe 250 milliliters, we might have a moderate urge that we need to go to the toilet, but often that bladder will stay relaxed and we can keep holding on for a little bit more. And it's only when we get to about 400 or 500 milliliters that there's stretch receptors in the wall that get activated, which tell the brain that I need to go to the toilet. And then the brain, depending on where we are and whether it's an appropriate time, will decide whether the bladder needs to contract and empty. And then we'll send a signal down to the bladder to get it to empty out and contract. What happens in an overactive bladder is that it doesn't matter what volume is in the bladder. For whatever reason, the bladder is sending signals up to the brain saying that it's full. And as such, sometimes the brain will send signals back saying that it needs to contract now, even though it's not the right time. The other common issue that's seen a lot in Parkinson's is constipation. But to understand that, we first had to talk about what normal bowel function is like. So normal bowel function, so we can have up to 1 to 3 bowel motions every 1 to 3 days. That's our rough guideline to say that we're sitting within that normal range, but it's more about how you feel as well. So if you're feeling constipated and you're feeling uncomfortable because of it, it's definitely worthwhile seeking a little bit of help for that. Okay, but if we look at how the bowel or the digestive system normally works, the stomach contents come into the small intestine, and in the small intestine, as it comes through, nutrients are sucked out of the stool to go into the body. As it comes into the large intestine after, the large intestine is responsible for taking water out of the stool for the body. So as it comes through, it will get drier and drier. So the bowel motion will enter through the large intestine from over here, and it's pushed through by a wave-like motion called peristalsis. And so it'll keep coming around all the way. Eventually it'll end up at the rectum. At this point, it's kind of shaped into that sausage form that we're used to, and it'll be stored into the rectum until it's an appropriate time to go to the toilet. So if we look at this kind of close-up of the rectum here, as it comes through, what happens is that the internal anal sphincter, so this little blue part here, will relax automatically. So that's something we don't really have control of. It's just the body's automatic response. But this muscle here, so this is one of the pelvic floor muscles that slings around the back of the rectum, helps to keep it taut, well, keeps taut, and the external anal sphincter, this green part, stays shut. And that's how we can control it, even though that other sphincter lets go. So only when we get to a toilet and the brain decides it's a good time, does this external anal sphincter relax and this muscle here relax. So it helps to unkink the bowel, and then also helps to open up so that bowel motion can pass. Okay, so then the reason why constipation is more common in Parkinson's is 2 main reasons. The first is that sometimes people can suffer from dystonia, of the external anal sphincter. So that spasm of that bladder, of that anal sphincter that we talked about. So that's that green part there. And of course, if that sphincter, which is like a circular shape of muscle, if that doesn't relax, of course, it's very hard for that bowel motion to pass through. The other thing that happens is that there can be a reduction in the dopamine producing cells in the bowel wall. So the bowel actually itself has its own nervous system and it has its own dopamine producing cells. But if there's a reduction in the dopamine in that bowel wall, there's less movement in the bowel, so there's less movement to push it through, so it goes through a little bit slower. And if the stool spends a longer time in the bowel, it ends up being drier because the bowel is pulling moisture out of the stool. So then once it gets to the sphincters at the end, it's actually a lot harder and it's a lot drier. So of course, harder to get rid of. The other thing, of course, that can happen is that there's issues emptying the bladder itself. So issues emptying your bladder all the way out. And so it's definitely normal to have a little bit of volume, a little bit of urine left in your bladder after you go to the toilet, but about 50 to 100 milliliters is normal. And sometimes with this issue, people will have 200 or potentially more left in their bladder. And so essentially, this is when you feel like you don't empty out completely, or sometimes it can be when you go to the toilet all the time. And it's because there's less space for the bladder to fill up again before it gets to the very top. The reason why this is more common in Parkinson's is that there can be stiffness of the urethral sphincters and the pelvic floor muscles. So if we look around, so the urethral sphincters will sit around the exit here. Of course, if they don't relax off, then it's very hard for us to pass urine. Also, as we remember from that picture, the pelvic floor muscles kind of sit underneath the bladder here. So if they're pulling it up and keeping it nice and taut the whole time, then of course it's a little bit harder for us to empty through the urethra as well. So poor ability to relax sometimes is why this is more common in Parkinson's disease. Okay. And so with pelvic floor treatment, there's a lot of different things you can do. I would always say that pelvic floor issues are always managed best by a healthcare professional. Of course, physiotherapy is one type, but there's other types as well. And this is because pelvic floor problems, they often need individualized treatment. And ideally, we're assessing for the problems and then treating them specifically. There's no blanket thing that helps everyone. The other reason why I think it's quite important to have a specialized health practitioner is that there's a lot of false information out there, unfortunately. So there's a lot of things that aren't necessarily pelvic floor strengthening, or there's some things that people that you can buy nowadays that aren't really helpful for people. So it's always best to have someone that can cut through all the noise. But just to give you an idea of some of the things that we do for those common conditions. So let's say for stress incontinence, where there's issues with leakage when there's the cough or a sneeze, often that's going to be pelvic floor strengthening route is the route we normally take. Sometimes it's really important to look at the core as well and that coordination. So making sure we're not maybe squeezing through our stomach when we're trying to contract, which just adds pressure down onto the pelvic floor. The other thing that we look at often is maybe we might need to modify fluid intake. There's definitely a group of people that drink too much, and sometimes that just adds more load onto the bladder, which can cause more stress incontinence. The other thing, let's say for urge incontinence, so leakage when there's a sudden strong urge, pelvic floor relaxation exercise is actually what we normally go to before we go to pelvic floor strengthening. Also, we can do a lot of things in terms of modifying our fluid intake. So maybe that's drinking less or drinking more sometimes, or drinking at different times. Also, we can do retraining. So that's getting out of those bad habits that we might have established. And electrical stimulation is an option as well. And for constipation, there's a lot of things we can actually do here as well, which I think people are surprised about. But often it's about retraining how we're going to the toilet, which actually can make a really big difference. Sometimes there's assisted devices that can help. So things like stools to lift up your feet are actually very helpful. And also modifying diet or seeing if we're taking like potentially the right supplements that can help and things like that. So if we look a little bit more at pelvic floor strengthening, so essentially when we train the pelvic floor or when we contract that pelvic floor, it should feel like a squeeze and a lift around the perineum. So that's the space between the vagina and the anus. And it should be followed by complete relaxation after. So it should be contract and then relax all the way down, which is really important. During this, our stomach and our bottom muscles should stay relaxed. So we shouldn't be squeezing our bottom as we turn on our pelvic floor. And often it's quite useful to use visualizations. So things that help you to visualize what that contraction feels like. So the most common ones I know of are stopping the flow of urine or squeezing to imagine you're holding wind, but it's whatever works for you, whatever gives you that strong contraction. The other things to note is that it's definitely okay if you don't get that contraction straight away if you're practicing. It's quite common to need a little bit of help, and that's where also physio can really help as well, to make sure that you're doing the right thing and we're not just reinforcing bad habits. The other thing that is a pet peeve of mine is that exercising your glutes or your bottom muscles isn't necessarily pelvic floor strengthening. I definitely have seen a lot of people that come and they're like, I've been doing pelvic floor strengthening for 6 months, but they're just doing exercises like these. And these are just not specific to pelvic floor. They're great exercises, but not great for pelvic floor. So definitely, just like any other muscle, the pelvic floor can be trained in different ways. So if I'm going for strength, changes in strength, I'm going to do something different than if I'm going for endurance. So for example, a strength contraction is probably going to be short squeezes, but as hard as we can. So I'm going to relax, 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 squeeze maybe for just a second, and then I'm going to relax again, and then keep going for as many sets and reps as we deem as necessary. If I'm working more on endurance, I'm going to work on a sustained hold. So I'm going to relax, 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 squeeze, hold, 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 maybe for 15 seconds or so, and then I'm going to relax off. And if I'm training coordination, like we talked about, I might go, so relax, 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 contract, and I got to hold it maybe while I'm breathing, while I'm squatting, while I'm doing a cough, and then I relax down. So there's different ways, just like any other muscle, to train the pelvic floor. And definitely, like as you get better, ideally we're making it harder all the time. So some examples of some ways to make it harder is I can do percentages. So maybe I relax, I contract to 100%, I relax to 50%, I contract back to 100%, to 50%, and so on. Otherwise, I can do things like pulses, which are quite hard too. So let's say I contract to 100%, then I squeeze a little bit more, then I relax, then I squeeze a little bit more, then I relax, then I keep going, and then relax after that. So there's a lot of things you can do, and there's ways to be specific about it to get the effect that you want.